Sorry, you've got me again, but I will be quick. I'm presenting the preliminary results of the LEMA study, that's lisdexamfetamine for methamphetamine dependence. This is a multi-year project with many, many, many people involved. Brendan actually prepared the slides, has done a lot of the work, or had some of the slides. Michelle Hall, who's here, was really involved as well with running this trial. So this is a many-person job. And I'm just presenting the preliminary results. Please don't take photos. And if anyone's online, please don't take screenshots because it hasn't been peer reviewed. And everyone knows that means the results could change, that our peers might decide we've misinterpreted it. So this is just our preliminary analysis. These are all the people that are involved. Nick Linzeris is the senior author on that, but you'll see that Michael Farrell, who's in the room here today, Craig might be in the room. There's many people in the room. There's a lot of people involved across a lot of sites. The rationale for so-called agonist therapies is that they will smooth dopaminergic dysfunction. So the idea is if you're exposed chronically to a dopaminergic agent like methamphetamine, you end up kind of running out of dopamine. So this kind of smooths that dysfunction and the things that go along with that, along with dysphoria and mood problems, but also provides some sort of background tolerance so that then if you use on top, you get less of the positive reinforcing effect, and then also decrease the withdrawals and cravings so that you get less of the negative reinforcing effects, so having to actually use to treat the withdrawal and cravings. Many of the agonists that have been studied, particularly methylphenidate, dexamphetamine, have been underpowered, probably underdosed, and suffer low retention, slow recruitment, which we also experience. I'll just heads up, sort of spoiler alert. A recent meta-analysis of all prescription psychostimulants of 10 RCTs didn't show anything significant at it when putting all the 561 subjects together, but looking at just those that received high doses of the stimulants and on the longer duration of treatment, there was an association with decreased use when they remove the high risk bias, the high risk of bias studies. So there are hints that this could work. We didn't study dexamphetamine. We studied lisdexamfetamine, which is a prodrug of dexamphetamine. So we only give it once a day. In Australia, we've only got the immediate release dexamphetamine that needs to be given theoretically 3 times a day. So this is licensed for attention deficit hyperactivity disorder, binge eating disorder to 70 milligrams. It's metabolized by the red cells into dexamphetamine, contains no free dexamphetamine, and theoretically, even if you crush it up and inject it, you still have to metabolize it into dexamphetamine. So the idea is that policymakers might be more likely to have this as a medication with less stringent daily supervised dosing, which is obviously a restriction in any kind of therapeutic treatment if people have to come every day for a medication. It has a slower onset, longer peak concentration, and longer duration of action than dexamphetamine. So it seemed kind of more suitable than dexamphetamine immediate release, which is what we've been using for more than 10 years in the clinic that I'm in, off-label for the treatment of methamphetamine use disorder. The study was a placebo-controlled, double-blind, fixed-dose, multi-centre study across 6 sites where people were randomised one-to-one active versus placebo. The first week, people were induced up to the 250 milligram dose daily that people were then maintained on for 12 weeks, then reduced over the next 2 weeks. People had to be using at least 14 days out of the previous 28 when they came to enrol in the study, and anyone with untreated hypertension, severe psychosis, peripheral vascular disease, things that the study investigators thought would interfere with the study, were excluded. And prior to COVID, people had to present daily for 5 days in the induction period. After COVID, we dropped that to twice, to only the first 2 days. Prior to COVID, people came in twice a week for supervised medication and urine tests, where we selected one at random. After COVID, that was reduced to once a week. And additionally, people were offered 4 sessions of manualised CBT, the Baker Nicole Lee manual that's available and shows some efficacy. So the main thing we were looking at was change in self-reported days of methamphetamine use and safety. We're also looking at treatment satisfaction and general health and safety. Quality of life. People were reasonably this was not an early intervention. People were at average age of 40, about 60 98% male in the group, very few people who didn't identify as male or female. You can see around 40% of people screened positive for childhood ADHD, and baseline use was pretty frequent, so 24 out of 28 days. So this was a group that was pretty severely dependent, had been using for quite a long time. We didn't have any serious, suspected, unexpected, serious adverse reactions, which is the thing that we really worry about in trials like this. And there weren't really any concerns from the safety data at all. Preliminary efficacy. Now, this is the thing that, this is the first time that you're seeing these data. They're not peer reviewed, so take them with a grain of salt. But we saw the past 28 days use. So if we compared what people were using at baseline to what they were using at week 12 for the 4 weeks before, there was no difference between the groups. We did see a difference at weeks 5, 9, and over the full 84 days. In fact, there were 9.5 fewer days in the active group than in the placebo group. And the active group also reported greater satisfaction, greater self-reported overall health. There was no difference in retention between the two groups, and there was no difference in engaging in counselling. And there was actually only an average of 1 counselling sessions per person. The limitations to the study really was interrupted by COVID. We had to suspend recruitment for a number of months, and then when we restarted, we made some modifications to the protocol. But even then, we only had 57%, and we only had 155 sample size out of the 180 we were initially looking for. Some people say self-reported days of use is not particularly convincing. We think it is, but in terms of the international literature, that may not be so convincing. And when we asked people to guess which group they'd been allocated to, the active group were more likely to guess correctly than the placebo group. I'm concluding that this medication appears well tolerated, liked, and that further research is warranted. Because on the secondary measures, it seems like it's positive, but it got affected by COVID. That's the truth of the study. But we do need also further discussion on what is a clinically meaningful outcome. Is a reduction of 9.5 days over 12 weeks clinically meaningful or not? And also, I think in future we do need to stratify by childhood ADHD status, because this is a medication that treats ADHD. Thank you to everybody, noting that this was conducted on the unceded lands of the Gadigal, Awabakal, Warramai, Darug, Bunurong, Wiradjuri and Kaurna peoples. And I want to thank all the participants, particularly the anonymous client that actually suggested that we should study this in the first place. This client said to me, there's a medication on the market, it's got a slower onset of action, longer duration of action. And this person was having dexamphetamine at the time, and they said this one will be better. So thank you to that person. It's taken us 10 years we've got here. We've got funding from NH and MRC, some additional funding from some other sources there that you can read on the screen. NCCRED's funded by the Australian Government Department of Health and Aged Care, and I have no conflicts to declare. And now I'm taking questions.
Thanks, Nadine. Is that on?
Yep.
Quick question, Simon Linton from Endry. The stuff regarding childhood ADHD is really interesting. Presumably most of these people were untreated as children, I imagine. And is it a retrospective assessment?
So we didn't actually ask about whether people had ever had a diagnosis. All we did was we did the Wender Utah Rating Scale, which is a retrospective assessment of childhood ADHD. Very difficult, as you know, to assess any kind of ADHD symptoms in someone who's using methamphetamine. A lot of the symptoms overlap. So yes, definitely retrospective, and we didn't ask about whether people were treated or not. Yeah. Great, thank you.